Okay. So good afternoon from India, and I'm Dr. Praveen Chandra from New Delhi, Medanta Medicity Hospital, and my colleague Dr. Abhinav, who is here with this in this case, and my other team members who are ready to help in this complex case. So Abhinav is going to explain the history and of this patient, why we are doing this.
So our patient is a 57-year-old gentleman. He presented with the effort angina from last 1 month, which was revealed on TMT as well, stress test, which showed a wall motion abnormality while the peak stress. So although the patient is also having a comorbidity of chronic liver disease, for he already on treatment by a gastroenterologist, although his platelet functions and platelet counts are less. So after due clearance from the gastro and the hemat team, so we are proceeding for his angiography. So angiography was done, which showed a critical, moderate stenosis of the LAD, proximal to mid. Mostly it is calcified and it is 80 to 90%. So our plan was to just fix it with cutting balloon and IVL followed by a drug-eluting balloon because his platelets are low. So we don't want to keep him on the dual antiplatelets. So yes,
So
sir.
here it is. So we have done this first angio shoot. You can see that the calcification is there, and this artery is a long lesion. So this is a challenging situation. Next, please. And the second challenge, as he already said, that the antiplatelet therapy will be an issue, especially in the long run or maybe even the midterm. So our strategy here is to first prepare this lesion vessel very well. And what we have done is we have taken a first wire in the LED, and there is a small wire again also you see in the diagonal which is gone there, but eventually we will put that into the LED because it is a FFR wire. I will tell you the importance of why we are doing this, because finally we want to end this procedure with a cutting balloon and a shockwave, and then followed by a drug-eluting balloon. If the FFR is good, if the lesion is well opened up, and it's like almost like a stent-like result, we won't put a stent here. Okay. So let us see what we have done. Next, please. So here you can see in the epicranial tight lesion, heavy calcification. We are trying to put this wire, which is not, we went with difficulty into that diagonal, but into the LED we could put a BMW, and this is the dilatation with a 2mm balloon. After this, we did IVUS. You can show the IVUS image, please. So IVUS only crossed till the midpoint because it is so heavily calcified. You can see that the
Catheter was stuck at that.
catheter was stuck at this place, and then we are pulling it back. And as we pull it back, more and more calcium, almost 360 degrees, and the entire artery is full with calcific plates and nodules. Okay, so I have taken this is the 3mm shock wave catheter. We'll see how it goes. Okay. It is going slowly inside. Okay, so let us check in the epicranial position. Epicranial, please. Okay. I will try to pass this distal tightest portion because that is, yes, we have crossed it. Okay, fantastic. So we have crossed this position of the tightest where even the IVUS catheter was not crossing. So I will do a balloon dilatation with this shock wave. Go up to 1, 2, 3, 4. Okay, now go up. Yeah, pulse.
Yes, pulses started.
Yeah. So we have started the pulses. You can see that the balloon is expanding slowly. Deflate. So 10 pulses given, and
Pressures are good.
okay. This red one is the catheter pressure.
Patient pressure, yes.
Okay. Yeah, everything is okay. Okay, go up 1, 2, 3, 4. Second set of pulses, again at the same point. Yeah, so it is expanding well. Yeah, abhi theek ho jayega.
Negative.
Deflate. He is having pain. We'll come back a little bit. Okay.
Pressures.
Go up. 1, 2, 3, 4. Yeah, go up. Ariocaudal. Deflate. Ariocaudal.
Deaerate.
So the patient is having angina. I think we can give him some rest in between. Check, please, whether the flow is happening or not. Yeah, the flow is happening, so we are not in a problem now. Okay. Check, please. Yeah, I'll pull back a little bit more. Okay, go up. 1, 2, 3, 4. Yes. So we are giving, this is now 40
Negative.
pulses given, deflate. Let him breathe a little bit. Pressures are okay?
Yeah, STT changes are
No,
there.
no, I don't see the pressures very well. Okay, let him now rest a little bit. I want the
NTG.
pressures to come slowly. Check, check. Okay. Give some saline, please. He was ischemic, so the pressures went down, but now it is recovering, as you can see. I'll give him some rest. The pressures are now back to 120, 130. Okay, that's nice. Okay. Okay. So we'll go do one more cycle. Go to epicranial. Pressures are okay now. Yeah. All fine. No ECG changes. Okay. So this is the most toughest point here. You can see. Go up. 1, 2, 3, 4. Yeah. Deflate. So this is the, we have given about 70 pulses. Some more I want to give. I want to cross this. Yeah, we
Yes.
have crossed it. We'll give some more. 1, 2, 3, 4. Okay, go up.
Negative.
Deflate. So that's nice. Go up. 1, 2, 3, 4. Yeah. I think it's quite looking quite nice. Deflate. 10 more.
10. One cycle, yes.
Yeah, so give one more. 10 more. 1, 2, 3, 4. 1. Go up. So this is the last set of pulses, and the balloon is fully dilated. So there doesn't seem to be any residual here. Abhi khatam ho jayega. So the
NTG.
pain will go away. Give some nitroglycerin. And now we will check with IVUS. Okay. Can we have this?
Pressures.
Pressures on the
FFR. FFR pressures. Maybe balloon dilatation has disturbed
Main.
the pressure point. It is going easily now.
So now the IVUS has crossed easily, and we'll do the IVUS. So this is the distal vessel is looking almost like 3, and yeah, so you can see that the disruption of the calcific, these plates, and also at this point is fracture in the calcium, and this is looking quite okay. Yeah. Okay, fine. So you can review the IVUS now.
Play.
Yeah.
Distally, it is around 2.6 maximally. Human.
So this is doesn't seem to be working now.
No.
Okay, we'll take it out. Okay.
Picture of now.
Okay, let's take a shot and then see. Nitro given?
Yes.
That looks nice. Okay. So we will take a 3 mm balloon.
Cutting.
Yes.
3 cutting.
So for further dilatation, 315, 15. You know why we are doing this? Because our aim is to not put a stent. And one of the issues with this patient will be antiplatelet therapy. Do you have 315?
310. Open.
Go to the iliocranial. Oh. More ilio. That's better. Check, please. Check. So you can see that this balloon is moving quite smoothly now. Okay. Epicranial. Short. I think a little bit more. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10, 12. Okay. Yeah. Deflate. Go up.
Pressure.
1, 2, 3, 4, 6, 5, 6, 7, 8, 9, 10, 12. Deflate. You come to RA quarter. Let the saline be continued.
Yes.
And check, please. Check. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. So we are doing, quite a reasonable amount of dilatation. We are not shying away with pressures. We are going up to 12 atmospheres, and you'll see how it goes. Deflate. Okay, check, please. Check a little bit. Okay. Yeah. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay. So this is serial dilatation using this cutting balloon, Wolverine. Deflate. Okay. Let's take a shot. Looks okay. Okay. Epicranial. To me, it looks quite good. And
340.
340. We have a 340
Deb.
DEB. And what is the size of this vessel? Should we go to 3.5 or not?
Distally, it was around 2.7.
3. It was 3. Yeah, it was 3. Distally, it was 3. And so since we don't see any major dissection, which we will see in other views as well, iliocaudal, please. Iliocaudal. And you can see, I mean, so the strategy in these patients who are high, very, very high bleeding risk, we can take a stent which has, indication for a high bleeding risk. But many times, if you are able to finish it, if there is no huge dissection, then in this view, there is appearing to be some dissection. We will see. Okay. Shall we do a OCT? Shall we do
OCT. OCT.
Need it.
OCT. Chal. Leo.
Okay. So in the meantime, we are taking this 3.5 into 30. No, 35 will be better. 35.
35. 35. 2.753.
35. RO quadrant. Show me the RO quadrant view. The branches are all fine. Everything seems to be okay. Go back. Go back. Go back. That's nice. Go back. Yeah, in this view also it looks okay.
No major dissection.
I mean, there is some, dissection, but not that much. It's not, impairing the lumen at any place. Iliocranial. This looks very good. I think, we are at a position where we can start thinking of just a DEB.
Yes.
Okay, but in the proximal part, we might have to do some more dilatations where just before that first diagonal. How much is the size of the vessel in the proximal part?
Now we
Give me
can
a same balloon.
free Wolverine. Live करना है एक मिनट. Live. Check.
Okay. I'll do another IVS run. Make sure that we have a good lumen. And then pressures. I don't see the pressures here. No, this is the left main. Now we enter into the LED. Yeah. The LED has a plate on the 6 o'clock to 9 o'clock position, but the lumen is good. Nothing to be done. This lumen is good. Again, it's okay. There's some, here we see some
Hematoma type of
hematoma or something like that. Although the lumen is okay. Okay, here it is breaks.
Nicely break.
Yeah, it is broken. Yeah, the lumen looks quite. You see, the plates have been broken so well. Yeah. Okay. Show me the MLA. So we'll keep looking at these MLAs. Show the MLA.
Distally.
Yeah,
This
yeah,
area.
here. It's
4.8, more or less 5.
4.85 square millimeters. Okay, इसको पकड़ो. So I'll do one more dilatation. Give me the balloon. And at this point also where there was maximum calcium, it's about 3.84 square millimeters. Okay. Okay. Okay, please. Yeah. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Deflate. So we go to high pressures here also. Check please, where are we? Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate. So this is a Wolverine 310, okay? Go up 2, 4, 6, 8, 9, 10, 12, 14. Deflate. It's fine. Okay, go up 2, 4, 6, 8, 10, 12, 14. Okay. Deflate. Check. Where are we?
Almost touching.
Check. Okay, go up. Aryo caudal. Aryo caudal. Aryo caudal. Okay. Check, please. We are fine. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate. Okay. So this heavily calcified lesion has been now treated completely. The with the 3 into 12 IVL shockwave, and then using a Wolverine 310. Okay.
330.
Okay, check.
Catheter out.
Looks
Yes.
nice.
Two 2.75, 30.
So now we are planning to take a drug-eluting balloon, and we will take a 30 millimeters. Yeah, so give me a 30 millimeters. Magic touch.
2.75. Will go
No,
on.
no. This
Bench
one. This.
3.5.
Yeah. Touch. Give me. So we are taking a 30 millimeter eluting balloon.
ACT. ACT.
ACT, yeah, ACT. So this is
ACT syringe.
30. Okay, connect it. Ready? Okay. going very easily. Not a problem. Okay, check please.
Yes.
Connect
Connected.
some more. Okay. Shall take a shoot. I think we're fine. Okay, go up. 1, 2, 3, 4, 5. Epicranial. So this is a 30 millimeters balloon. And we have taken a slightly higher size, but we are going at low pressures. Okay. So
Pressures.
yeah, and we will do it for at least 1 minute. Patient will have some pain. अभी हो जाएगा ठीक. So this is the dilatation using a magic touch sirolimus eluting balloon, 30 millimeters in length. Okay, and you can see that the dilatation of the balloon is complete. There is no residual anywhere, which means that the lesion has been fully treated. Okay. It's 1 minute now, and we will continue for another 30 seconds if he tolerates. Just 30 seconds. बस 30 सेकंड और 15 सेकंड. He is having some chest discomfort, which is now natural, but typically this is 1 minute 30 seconds. Deflate. So we are deflating it now because he can't tolerate anymore. Otherwise, I could have gone even a little bit more.
Proximal 3.5. One more.
Not really. Can take a shot. Looks nice.
There is some haziness in the proximal part.
We will see. Are caudal? So we are keeping the stent thing provisional. And there is some dissection though, but it is not really flow limiting. Ileocranial. Now we see that probably we might have to fix a stent. Stop. The lumen is very good actually. I don't think he will have any issues with this. Yeah. Areocranial.
NTG.
Yeah, lumen is quite good. It appears that we are almost done and no major flaps anywhere, and the flow is very good. We can even check the FFR if you want. Should we?
No.
Okay. The bar is not functioning well, so we have to get a new one. I don't think that's really required. So we can just stop here.
Yes.
Yeah. Okay. So we are almost done, and I'm just going to take a shot. It's very nice. Get almost a stent-like result, and the residual seems to be very less. Okay. Stop. Back. Yeah, I think it's quite good.
Yes.
Yeah. There is nothing, no haziness, and there is no.
Major
And the
flaps.
area was above 4.5
4.8.
to 5 square millimeters everywhere. 5 square millimeters.
More or less a hematoma
Yes.
type of thing. More.
Yeah, I think that will heal. Okay, so we are done. So thank you very much for being with us, and this is what we wanted to show you, this strategy of stentless angioplasty, where you just do good amount of angioplasty of the vessel and then finish it with the drug-eluting balloon. So I think we can sign off now from India, and hopefully in the next after 2 weeks we will be back again when this resumes on I think after the PCR. Thank you very much. Bye-bye.
Thank you.
This is really going to be a unique platform. People will be able to tune in and see interventional live cardiology cases from around the world performed by some of the world's best operators. The real advantage of this is that they'll do 9,000 cases spanning the whole spectrum of interventional cardiology.
For MedStream 360, we'll be extending 24-hour live cases so that you can watch cases in your own time zone, time frame at your own convenience.
MedStream 360 is a transformation in medical education. With MedStream 360, you can see wherever you are, in your office, at home, in your computer, in your iPhone or your laptop or your iPad, any case in any topic whenever you want. And not only that, you'll be able to see the best operators from around the world sharing their live cases with you.
There are several unique attributes of MedStream 360. We have no moderation and there is no time restriction. The majority of the cases, an overwhelming majority of the cases, are viewed not live but archived cases. So to enhance your viewing experience and to customize the archived cases to your requirement, we have assembled an army of physician video editors who have been experimenting with different formats. All of this is being done to enhance your experience and to make MedStream the most beneficial.
The concept here is to provide easy access to more live demonstration cases to more physicians. I think live demonstration cases are probably the best way to learn the nuances of our field. And the more we can do to bring cases of interest to our community, the better we'll all be. This is a great way to exchange information and to keep up with the latest in interventional cardiology, period.
So I look forward to welcoming you to MedStream 360, and please give us your feedback. We hope you enjoy it as much as we're enjoying putting it together. Thanks very much.
79-year-old patient with worsening dyspnea. And of course, patient has multiple PCIs before and CKD, severe AS, and then was found incidental 6.4 centimeter fusiform dilatation of the infrarenal aorta.
As you can see, normal RV function, no pericardial effusion, thickened and calcified aortic valve leaflets with decreased excursion.
Yes, the CT scan shows a very good annulus and LVOT for transcatheter transfemoral TAVR. Annulus area is around 498. The LVOT is around 426. There's not much annular LVOT calcium, so it's very good valve for 26 sapien. Next slide. Very generous sinuses, more than 35. STJ is generous. Next slide, please. And good coronary clearance, good STJ height.
When looking at the aneurysm, a few things are really important. One is the proximal neck below the renal arteries. The aorta there is measuring around 23 millimeters in diameter, and the length of the neck is over 15 millimeters, which is what you want for an infrarenal endovascular aneurysm repair. The iliacs are measuring around 16 millimeters, both common iliacs, roughly around the same. Both